One moment. Okay, there we go. Great. So we want to welcome Chloe. She's an international development consultant with over a decade of experience specializing in program design, monitoring and evaluation, and gender equality, disability, and social inclusion in the Asia Pacific. She has 7 years of experience, much of which has been in Vanuatu and Myanmar, and she has led strategy and technical inputs for projects funded by DFAT, MFAT, USAID, BHA, and the EU, as well as UN agencies across various sectors, including climate change adaptation, SRHR, WASH, livelihoods, and violence prevention. Her consulting work blends participatory methods with evidence-based design to support inclusive, locally led programming. She frequently leads theory of change workshops, baseline and endline evaluations, donor proposal development, and organizational capacity. So, capacity assessments. So many things she does. We're thrilled to have her with us, and we're thrilled to have her as part of the larger sexual well-being team that has worked on this project. So I will hand it over to you, Chloe.
Thanks so much for that introduction, Ragnar. And it really is a pleasure to be here today to share about the research that we did in Pentecost last year in Vanuatu. This is actually my second opportunity presenting this research. In June, we presented the research to a number of stakeholders in Port Vila, Vanuatu, which was really exciting to see the engagement there at a national level in Vanuatu. And today we'll also be sharing how the results and findings of the research will shape part of the Plan 'em Good Family Belong You Me project that SWA and Vanuatu Family Health Association conduct. So, for those of you not familiar with the research, the purpose was to explore knowledge, attitudes, and barriers to sexual reproductive health for young people. In the case of this research, young people were 14 to 34, and I'll talk more about why that age group was selected later in Pentecost, Vanuatu. And the title of our report, It's Easy for Them to Access, but They're Frightened, really encapsulates some of the findings we heard and comes from a health stakeholder who shared, young people are not using family planning. It's easy for them to access, but they're frightened. Okay, so what is the Plan 'em Good Family Belong You Me project? It is a project that is delivered by Vanuatu Family Health Association, which is a really incredible local health organisation in Vanuatu of which SWA and before that Family Planning New Zealand has a long history of partnering with. They deliver some really pivotal core outreach work in Vanuatu. And the project is funded by the New Zealand government's Manaaki Fund. It's the aim of the project, and this I think helps situate where the research fits in, is to reduce unplanned pregnancies and STIs in Ni Vanuatu in hard to reach communities in northern Vanuatu. This is the second project I've worked on with Vanuatu Family Health Association and SWA, and I can confirm they really are hard to reach communities. This work builds on previous research as well that was conducted under phase 2 of the project, which explored sexual reproductive health access and barriers across all age groups in rural Santo. So the main difference between this research and what was conducted previously is this research is youth focused. So the research conducted in Santo was across all age groups. And the other key difference, apart from geography, is that this research also conducted in-depth interviews with men and young men as well, and not just focus groups with them, whereas that Santo research did in-depth interviews with women, but just focus groups with men. So in case you're familiar with the history of the project, that's what's different about this research. Now, again, for those of you who are familiar with Vanuatu, you will know all of this, but for those of you who aren't, Vanuatu is an archipelago of 83 islands. More than 60 of those islands are inhabited, and a population of just over 300,000. So we're talking about really small and dispersed populations. It's also, which as you can imagine, would be a nightmare for health service delivery and also very expensive. It is a young population. Most of the population is aged under 25. Vanuatu also has the honour, perhaps, of being frequently recognised as one of the most vulnerable countries in the world to the impacts of climate change and disasters, as well as frequently experiencing natural hazards. You might be aware that in December last year, there was quite a major earthquake which damaged the capital city of Port Vila. In 2023, the country experienced a Category 4 cyclone and a Category 5 cyclone within 72 hours of each other. So it really is, when we talk about climate change increasing in severity and frequency, Vanuatu is living that reality, and that obviously has impacts on people's ability to access healthcare. Pentecost Island, which you can see on the map is in the north there, is rural communities dispersed, living both inland and coastal areas. For this research, we went kind of as far north. It's not clear on the map, clearly marked on the map, but roughly where that big Pentecost is, we went about as north as there, past Mel-Cici. And then we went as far south, Londa at the bottom of the map, between Londa and Bunlap. So we went to some coastal communities there that were only accessible by some quite serious hikes, I would say, up some hills and boat travel. So again, really emphasizing these are hard to reach communities that your project is working with and that we conducted research with as well. What is the situation of sexual reproductive health in Vanuatu? Like a lot of the Pacific, there's high rates of sexually transmissible infections, STIs, unplanned pregnancies, and unmet contraceptive needs. And those unmet contraceptive needs are highest among adolescents. Adolescents and young people carry the highest burden of that. Among young women aged 15 to 19, close to 60% reported having unmet contraceptive needs. And that's from the latest multiple indicator cluster survey. I think I've got that acronym right. Um, that's about 20% higher than women aged 20 to 24. Against this backdrop, rates of violence against women and girls in Vanuatu are some of the highest in the world. And you'll see how harmful gender norms and a lack of agency plays out in women being able to access sexual reproductive health later in the research findings. Um, a report by the Vanuatu Women's Centre found that 60% of women who had ever been in a relationship had experienced physical and/or sexual violence at the hands of an intimate partner. So really high rates of violence. In Panama province, so Pentecost Island is part of Panama province, has the highest adolescent birth rate in the country. So this is a country with some of the highest adolescent birth rates in the Pacific. And within Vanuatu, Pentecost, where we conducted this research, has some of the highest, or has the highest in the country, close to double the rate of the rest of the country. Vanuatu, as well, before I get into this section, is also a very traditional culture where sexual reproductive health is not spoken about openly, and it's not spoken about openly with young people either. So one of the challenges when we were discussing the methods, essentially how we're going to do this research, was about how can we create a safe environment that young people feel comfortable discussing what is traditionally a very taboo and sensitive topic. And honestly, like sexual reproductive health is a sensitive topic in a lot of cultures and a lot of contexts as well. This isn't something just related to Vanuatu. So our research was largely qualitative in that we asked people open-ended questions. It was interviews. There was a very small survey portion, but that was quite voluntary. Like I said, young people were referred to as people 14 to 34. And you might be wondering, well, 34 isn't traditionally a youth. In Vanuatu, there are a number of definitions used for youth. The one that's most commonly accepted is people aged up till 30. The reason we, at the design phase of research, spoke to people up or planned to speak to people up to 34 is because one, like I mentioned, really dispersed small populations. We weren't sure how many people we were going to be able to speak to in a younger age range. And then also, we weren't sure how comfortable young people were going to be part of the research. So from the start, we planned to speak to people slightly older. Age was the only criteria. So it included young people, those aged 14 to 34, regardless of marital status, sexual activity, or use of contraception. Obviously, 14 to 34 is quite a big age range, especially talking about a topic like this. So, where possible, we did disaggregate or separate those groups further and have kind of a younger group and the older group where that was possible. So, we carried out 20 focus group discussions, 12 with young women, 7 with young men, and 1 with older women. 22 in-depth interviews, so one-on-one or one-on-two interviews, 12 with women, 10 with young men, and then 10 key informant interviews with health and community stakeholders. And those community stakeholders ranged from area administrators, so sort of a provincial government, municipality administrator, best way I can think of describing their role, to police officers, to teachers, to nurses, village health workers, etc. Quite a range of key informants that we spoke with. I wanted to share how we did it. That's sort of the what, because I think it really set us up for successful interviews, and I think it's just a really good way of approaching interviews with young people. We used a fictional story or a vignette to create the safe environment for young people to openly discuss topics such as safe sex and consent, STIs and HIV, contraception and teenage pregnancy, access to services. And so this fictional story was designed to provide a realistic scenario that young people have probably experienced in their own peer group, but a way that they could give their thoughts and opinions without giving a personal account. So this promoted more open discussion. And certainly throughout the reflections we had with the team, during the focus group discussions, this proved to be highly effective to get people talking quite openly and giving quite candid responses. Our vignette or our story followed Alex, who was an 18-year-old, and Maria, who was his 17-year-old girlfriend, as they discussed having sex for the first time. And the narrative and the questions that followed explored, like I said, topics of consent, access to contraception, where they might get it, where they might find information, teenage pregnancy, who would be impacted more if Maria was to fall pregnant, etc. Most of the focus group discussions had a total of 3 to 8 participants, so they were quite small. Um, and then for the in-depth interviews, they followed similar topics as well as puberty and menstruation, marriage, custom practices, childbirth, and raising children. What we found, and this wasn't something designed, but that we found that a number of young people felt more comfortable initially to take part in focus group discussions, part of the group setting. But then after they participated in the focus groups, a number of particularly young women, asked if they could be part of the in-depth interviews, the one-on-one discussions. The other thing I would say that you can perhaps see on the screen that I think also was really appropriate for the cultural setting and context was we had young people facilitating the research. So Vanuatu Family Health Association worked with Youth Challenge Vanuatu with some youth volunteers. That's Claude. They're overseeing some of the young boys. They're doing the survey bit at the end. And Saviana, who is the formidable project coordinator of the project, also facilitating interviews there. So young people facilitating and a sort of peer group setting with a story also really helped. So that was how we conducted the interviews and how we conducted the research. What did we find? Interviews showed some really critical barriers that impede young people's access to reproductive health services. There are often, and you can see from the list on the screen there, There are often a range of underlying issues, but also quite intersecting issues that prevented young people from even attempting to access family planning services and information. And what this means, I was quite surprised we didn't see physical access come up as sort of a key leading barrier, even though these communities were quite remote. Um, and I'll talk about this a bit more later, but it could very well be a case of you don't know what you don't know. You don't know that physical access is a barrier if you don't know about a contraceptive type to go and access. Throughout the interviews, and we heard this from young people themselves, we heard this from community stakeholders, including health care workers, that young people feel ashamed and afraid in accessing contraception from health services, even when they are available. Um, and this was especially if young people weren't married or didn't have children already. We spoke about the impact or the prevalence and occurrence of teenage pregnancy and the impact that that has on the lives of young people, thinking about Pentecost having or Panama having some of the highest rates of adolescent birth rates in Vanuatu. And what came out is that in it was very much quite stark in seeing those statistics come to life that teenage pregnancies are increasing and the age of first-time parents is decreasing in the communities we went to. Um, Teenage mothers face greater stigma and disruption, but we also heard throughout the research that increasingly young girls who are giving birth are returning to school. In terms of knowledge gaps and cultural taboos, really widespread misunderstanding about contraception and what that does to the body. But that, like I said, in terms of those interrelated links, um, often stemmed from just a lack of to no understanding of how a reproductive system works or people understanding their body. So to kind of do a bit of a deeper dive into some of these researchers, these results, um, availability of contraceptives were mostly widely available with Jadel, which is Jadel is frequently used as the term in Vanuatu to refer to the implant, condoms, Depo-Provera, the injection, and the pill accessible at a lot of clinics. Remote communities also reported to have regular access to condoms and contraceptive pill and dispensaries. And this was shared by a health stakeholder who shared access to SRH is very accessible, but some services are not available at the clinic, for example, STI testing. So it's only treated if symptoms are presented by the patient. All contraceptive methods are available except the IUD. Um, the mentioning of STI testing not being available is also perhaps means that there's underreporting because as we'll get to misinformation, people have a very low understanding of what an STI symptom is, so may not be aware that they do need to seek access. Like I shared, physical access and cost were rarely reported as barriers, but this might be underreported due to people not knowing or seeking contraceptives not available nearby. And what I mean by that is, I don't know if you can think back to the map, but some of those really remote communities that we went to by boat, if a woman in that community wanted to access implant, like the implant or Jadel as it's called in Vanuatu, for instance, she would need to walk at least 20 minutes down a very sort of challenging, steep path. So if she had a physical disability, for instance, if young children might be difficult for her to walk, make that walk in the first place. The boat trip, the cost of a return boat trip to that community to the nearest clinic that provides this service is about 110 New Zealand dollars. And then you would then have to walk about 20 minutes to the clinic. And when we were there, the clinic, who has amazing staff, but often didn't have water, and so they would close at lunchtime. So whilst I just want to highlight, whilst physical access and cost didn't come out as availability, I suspect it is a bit of a case of you don't know what you don't know. And if you're not going to access, you don't know that those would be prohibitive factors, for instance. Misinformation about contraception and poor knowledge about STIs was rife. What really surprised me as well is that it wasn't just misinformation and misunderstanding amongst people who hadn't used contraception, but as this quote shows, it's also really prevalent in women who were using contraception. So this quote is from Julie, who is 22, and she has an implant, and she shared, I am scared that all the blood is being piled up in my uterus and will develop into cancer and kill me later. So I do not like that family planning is causing my period to stop and storing all the blood in me. Poor knowledge, like I shared, about contraception, how it works, common side effects, um, menstruation, and reproductive health really combined to lead to a fear of contraception use. There was widespread belief amongst men and women, and also, like I said, I was surprised women who were using contraception that contraceptives can cause cancer and infertility. Um, as I shared, poor knowledge about contraception, how it works, what common side effects are, particularly for contraception that means women may see changes to their menstruation. People assumed that if they weren't seeing their period regularly, that would cause cancer or long-term infertility. Or as Julie shared, just a lack of understanding about reproductive system and how contraception works. There was really limited understanding of STIs. Most in the focus groups, most people could only recognize HIV and gonorrhea and by recognize, I mean name them, but weren't able to name any symptoms or transmission routes or how to prevent them. And cultural taboos restrict discussions on sexual reproductive health and safe sex. So against this backdrop, there's cultural taboos around how you could discuss some of these things openly as well. The impact and stigma on young people accessing sexual reproductive health, especially if they weren't married, was quite significant, and seemed to be greater for young girls or young women compared to boys. So, as this health stakeholder shared, they're frightened because they think that we might talk about them. We need to have men to talk with men and boys, yeah, men and boys, and women to talk with women and girls. And girls at the secondary school we went to and did focus groups with shared the nurse here at the school is an older man, so it's hard to go and ask questions. And we seem to see that come out that the impact of different um, healthcare workers having a different sex played out more with young girls if they had to go and see a man versus if the healthcare worker was a female nurse, for instance, for boys. Um, Fears of or feelings of fear and shame were reported to stem from being worried about being spoken about and subject to rumors and gossip. And especially in a small village setting where health workers are often family members or well known to the young person, it's really hard to be anonymous to access healthcare in really small communities. Facing judgment from clinic staff for being considered too young and having clinic staff tell their parents that they are sexually active and or came to access contraception. And like I said, this was exacerbated for young unmarried women, especially if the healthcare provider was male. I should say that whilst it was really sort of commonly accepted and reported that young people were afraid to access sexual reproductive health services, the vast majority of healthcare workers we spoke to were really open about providing services to young people. So they acknowledged that there was this barrier of fear and shame, but that they were very open to providing services in a safe and non-judgmental way for young people, which is quite a positive thing, I think. So if you think back to that perhaps shocking statistic around the rates of violence in Vanuatu, it is perhaps not surprising that we found that gender norms limit women's decision making and their access to accessing contraception. And if I had to name the perhaps greatest barrier that we came across in the research for young women to access contraception and services, it was certainly the role of men. The gender dynamics were also evident in discussions about consent and safe sex as well. So, as these two quotes show, sometimes girls want to use family planning because they don't want to get pregnant, but their boyfriends stop them from taking it because they want children, or they think um, if their girlfriend takes it, contraception, they'll cheat on them. If you think back, Alex and Maria is referring to the couple in the focus group discussion. So in the focus group discussion, we asked as well, what would happen if Maria took contraception without Alex knowing? So essentially, what would happen if a woman took contraception without her partner knowing? And this was a very common answer. Alex will beat Maria. Alex will be angry with Maria and will explain to her that she needs to let him know before she does something like that, take contraception, because he is the boss. Um, so there's a few things playing out there. Certainly, this belief that if women took contraception, it would lead to infidelity, or they were only taking contraception so they could have an affair, was shared throughout both the women's and men's focus group discussions and the in-depth interviews as well. It was also, like I shared then, it came out in the women's interviews as well. It was often something that was internalized by some women, especially married women who believed that young girls and women only wanted to take contraception to have affairs or with married men. One woman shared, when you're married and with your husband, there's no need to take family planning. I don't think it's a good idea for young girls to take family planning because then they'll just start having affairs with married men if they know they can't get pregnant. Very few men reported that women should have full autonomy and agency in making decisions about family planning. Women often shared in their relationships that decisions around contraception or family planning were made together. So they would, if you ask who makes the decision, it would be we make it together. But further sort of unpacking of those answers often revealed that men were the ultimate decision makers. And there were numerous cases where you would ask who makes the decision. I would say, oh, we both do. But ultimately, and we heard that even in cases where women had shared that they wanted to take contraception or use a different kind, and their husband said no, and therefore they didn't. Men and women shared, like I said, if a woman took contraception without her husband knowing, he would be angry and they would likely be beaten. So, several reasons were provided as to why men don't want women to use contraception. Like I said, the belief of that will lead to infidelity. It also links to that misinformation piece. There are a number of men who shared the reason they don't want their partner to take contraception is because it causes cancer or other illnesses. So that was common across both men and women. Wanting a greater number of children or that family planning contraception means that women won't be able to have children in the future came up, but perhaps not as much as you would think for a traditional culture or custom. And then simply not being educated or understanding about contraception, which again links to that misinformation piece as well. So it is perhaps not surprising when we have a lot of fear around accessing contraception for young people, especially if they're not married, and also a range of different barriers that while on the whole, when we did interviews with stakeholders, community leaders, healthcare workers, they shared that on the whole, unplanned pregnancies were decreasing and also the size of families were decreasing. However, we heard time and time again, and this links with that adolescent birth rate, that in Pentecost, teenage pregnancies are increasing and the age of first-time parents is decreasing, with many of the interviews that we did reporting girls aged 12, 13, 14 are becoming parents, and this was younger than before. So, as this first quote shared from Flora, sometimes young girls, some who are 12 years or 9 years old, have children now. Some who are 10 or 11 years already have children. Normally, if you're 20 or 19, then you get pregnant and have children. But now, children who are 11 or 12, they get their period and they're having sex and children. And so, this is, I think this quote really demonstrates as well that the age of children decreasing, having the age of parents become having children is decreasing is something that's new. Parents have always been perhaps young, but that age is decreasing in Pentecost. We also heard that when an unplanned pregnancy occurs, young women often shoulder the burden of responsibilities, whilst boys and men largely remain unaffected. There is consequences, but that these are to a lesser extent. And Louisa shared, Louise is now 22, but she became a mother at 19. And she shared, when I was pregnant, I didn't feel happy. I had regrets before I had my baby because I wasn't ready. What we also heard throughout the interviews as well is for people in, say, Louisa's situation, is a lot of parents are then forced to get married, which is something that we heard both from young men and women after they had had children or whilst they were pregnant. What was interesting throughout the research, so as we're hearing this throughout our interviews, what was becoming really interesting to us was that we weren't seeing young girls with babies in the community or meeting young girls, quite young girls who were pregnant. So we started to ask the questions of what happens, or further questions, I should say, what happens? Where are these young women that we keep hearing about? And what several people reported was that teenage mothers can return to school and complete their education after giving birth. So the babies are typically then being raised by grandparents as well. And that also was a sentiment we heard from one of the teachers at the secondary school, boarding school we went to do some interviews as well. So I feel like you can't really do justice to a qualitative research report during a presentation. There are so many really interesting quotes and case studies that are shared throughout the report. I'm obviously biased, but if you are interested in some of these stories, please do go and have a look at the report. What I think is quite exciting from a research perspective about this report and the work that we did is that it's going to be used to support the implementation of the project. So it's not just going to be a lovely report, but it's actually going to be used to inform changes to the project. And perhaps some of the team there can share more about this. But in terms of recommendations from the research, and about how we can improve some of the access to sexual reproductive health for young people. Looking at developing youth-focused programs that are led by young people. So traditionally in Vanuatu over the years, and I think to be fair, every generation says the same about of the next, that they don't respect their elders and they don't listen to older people, but there is real value in having peer education being led by young people to discuss these issues. And we found, I think, a real factor that we had such rich data was the fact that we had young youth-led research as well. There is a need to deliver school-based education on puberty and reproductive health. And what was really pleasing actually is that, and surprising to me, to be honest, was that one of the area administrators, when we were talking to him, he was like, can you come and do a training to our year fives and sixes next week? It didn't work out for logistic reasons, but there is also demand, even though it is quite a taboo topic. I guess because community leaders can see and provincial leaders can see how this is playing out, that there are quite young people having children, that there is a real need to do some school-based education. And despite it being a sensitive topic, there is an appetite there for that. This is easier said than done when you think about the locations that the Vanuatu Family Health Team deliver their outreach clinics. but trying to address confidentiality and privacy concerns of young people. When I say that, I mean the services and outreach clinics are delivered in quite sort of communal spaces, and some of the contraception services are delivered in more sterile environments. So it would perhaps be obvious where people are going. But again, I think when there is that opportunity with healthcare workers who are quite open to providing services to young people, I think there is an opportunity to help really dispel some of those myths and fears about confidentiality. Develop accessible IEC materials. So what that means is just visual materials, really taking into account some of the low literacy rates as well, that explain potential side effects of common contraceptive methods and dispel prevalent myths. And I think that is something that, because some of the women who've received contraception, for instance, an implant, may not be able to go back to their healthcare provider or have access to healthcare to be able to do follow-up if they notice something. So to be able to have some information that they can take with them as well. So both as a way to encourage people to access services, but also to help, I guess, assure people who have received contraception as well. There is a real opportunity, and this fits within the scope of the Plan and Good Family Belong You Me project, to help train community health level healthcare workers like village health workers on how to dispel misinformation effectively and how to address some of those common myths, especially around contraception. And then lastly, and perhaps just as importantly, is to engage young men in reproductive health conversations. This is, I think, really essential for young people to be able to safely access, young women as well, to be able to safely access reproductive health services, and also support young men to increase their knowledge and understanding. So I'll leave it there. There's a lot more that I could talk about, but hopefully that gives a good summary of what the research was and how it will be used as well.
Thank you so much, Chloe. That was really interesting and really compelling to hear about all of these different factors and how they're sort of creating these conditions and these outcomes for people in Vanuatu. I'd like to open the floor for any questions. If you do have a question, you can just speak up or raise your hand if somebody else is already speaking. So does anybody have any questions? And maybe Chloe, if you would like to stop sharing your screen, we can all see one another. And if you're able to and up for turning on your camera, that's always nice to be able to see one another.
I had a question about the the accessibility. You mentioned about the boat that goes out to the one of the islands to access the clinic there, and you said that it's like 110 New Zealand dollars, which of course blew my mind. I was just like wondering, is that like a formal? Does that mean is that like a formal ferry where you buy a ticket online, or or is there like are there also like local fishermen who can take you over, or what is the situation? Are the people from the village actually going online and buy tickets? I don't think so, but yeah, maybe you can elaborate a little bit more on that.
Yeah, great question. It's certainly not a formal ferry service. It's what I wish I had a picture. It's what would locally be called a banana boat, so like a
Yeah,
little speedboat. Fuel in Vanuatu is really expensive.
Hmm.
Um, so it's not like people are making big profits from the transport. It's just the cost of transport. People, I guess you wouldn't. So what I suspect would happen is you wouldn't go over just for your contraception. You'd be
no,
going over if people are going to sell things at a market or things like that. We did hear from a healthcare worker just more broadly that it is an issue in terms of people's health-seeking behaviors for general health ailments as well. But one thing about Vanuatu as well is like community is community.
yeah,
Someone would probably know someone if you did have an urgent health issue, someone would know someone who owned the boat and would band together and try and get that. But yeah, there's no sort of casual trips across to the main town.
Okay, thank you. I've actually been to Vanuatu myself. I sailed from New Zealand to Vanuatu and spent a month there. I was just the gender-based violence, the violence that there is between men, yeah, what you also brought forward. I find it interesting because Vanuatu is also known as like one of the happiest places in the world, as you probably know. And yeah, do you know like how that can coexist? Because
That,
I did feel like that as well because I spent quite a bit of time in East Africa, and of course there's a lot of similarities in traditional communities, also the poverty. But I did feel like when you see people in the streets in Vanuatu, Port Vila, I didn't get the chance to go to the outer islands, but um, extremely happy and positive and friendly. And yeah, when you present those numbers of the violence to women, you just like that just makes you sad. So you wonder like how can it be one of the happiest places in the world?
yeah, it's something I've really struggled with actually before I moved. So I've lived in Vanuatu on and off over the past 10 years. It was an
Mm,
interesting thing that when I first moved in 2014, I think Vanuatu had just been named happiest country in the world. It recently was again the
yeah.
2020, 2024. It wouldn't be, it's a shame someone for Sabiana isn't on the call, I don't think, but my sense of it is actually that violence against women is so normalized that that is kind of your lot and that sits separately to your other experiences because it's true Vanuatu um, is
Mm,
any engagement you have with men and women in Vanuatu is just such a joyful experience typically. But it does sit behind those really high rates of violence as well. And I suspect part of it is around just how normalized it is.
yeah. Oh, yeah. That's an interesting perspective. Yeah. Thank you. Interesting. Where can we read the whole research? Sorry, if it was.
Um,
I can tell you that it's on
Yeah.
our website, and I will share it with this group who RSVP'd for this event. I'll share the link with you so you can read the full report.
Perfect. Thank you.
Any other questions?
Chloe, I had two questions. It's Sue Reed here in National Office at Sexual Wellbeing. One of the things that I hope I didn't miss it, was about the role of the church, and whether you gathered any information on that. And my second question was a bit like Josephine. I'm sort of interested in this dichotomy maybe between the teen pregnancy rates, the sort of the stigma. How does that work, that we can't talk to young people about being sexually active, but the sort of teen pregnancy is such a reality in our lives? I'm kind of interested in how you saw that as well.
Yeah, great question. The first one, you didn't miss it. It didn't come out. So for those who may not be familiar with Vanuatu, highly Christian country, about 83% of the population identifies as Christian. Christianity and culture go kind of hand in hand. Faith leaders highly influential. So cultural and faith perspectives didn't really come out. Faith came out explicitly in one interview, in one focus group discussion with the secondary school boys, where a boy said, "It's against my religion." But whilst it didn't come out explicitly, gender norms and the sort of patriarchal society is highly linked to Christian principles that may see men as the head of the household and the decision maker, and custom that sees community leaders as chiefs. We asked as well health stakeholders around the influence of church and faith leaders and whether that was a barrier. And most of the health workers said no, it wasn't, not anymore. Perhaps traditionally it was, and perhaps more with Catholic faith, but that wasn't as much of an issue on Pentecost, but that faith leaders weren't a barrier. So that, yeah, it was also quite surprising in that it didn't come out explicitly, but implicitly, when we look at some of those gender norms and roles that see men as key decision makers, I think it's all very interrelated. And your second question regarding the teen pregnancy and need to talk to young people, I think we've probably seen this world over. There is perhaps a perception that if you don't talk to young people about sex, that means they're not going to have sex. And I think we know how that plays out. I think and like I said, that it was really pleasing for that area administrator to request if the team could do some training in a primary school. I think reality is slowly changing on that. This is a much bigger research piece. I'd be really interested to know why in Pentecost the situation is so stark compared to other rural areas as well. And yeah, how that age range is changing sort of outside the scope of this research. But I think there is certainly an appetite to start talking to young people. Healthcare workers certainly were open to it, because I think now the reality is people can see that what happens when you don't talk to young people about sexual reproductive health. It's a really good point, though.
Thank you.
Thank you for that. I just want to share Michael, who's from Te Whatu Ora, Health New Zealand here, has made a comment. Thank you for your amazing work. And Deborah, who I know is still on the call but not feeling well, said, wonderful presentation with compelling evidence. I wonder whether the website about period health in New Zealand would be a useful resource for young people in Vanuatu. Has a very NZ Maori perspective, but a resource they could freely share and use, collaborative design approach. So there's Period Health NZ. So interesting to consider the ways that existing resources might be employed in that context. But of course, there's always the cultural adaptation that needs to happen. Just picking up this thread from the comment from Sue, I do wonder, is there some kind of social capital that young women gain by becoming mothers in these contexts, and they're sort of have a sense of purpose or welcomed or sort of honored in different ways than they would be as, teenagers without children?
That's a great question, Ragnar. Yeah, and I would say we heard mixed reports. So typically, there's one quite, I don't want to use sort of emotive language, but to me it was quite a gut-wrenching story. We heard of a young woman who fell pregnant in her last year of school, and her parents' reaction, which was to beat her and then ultimately force her to give that baby up for adoption. Conversely, so some young people who'd become teenage mothers had quite difficult experiences with their role in community. Others, however, when we spoke, because we did have an open-ended question, the focus group discussion about what would happen if Maria became pregnant now, and people were like, you're a woman now, like you just get on with it and you would be respected. So I'm not sure if I'd go as far as social or community capital, but certainly your role would change in the community as well. Interestingly, once you have children, it also seemed that it would be a lot more accessible it would be more appropriate for you to access family planning or contraception as well. That was certainly something that did come out.
I think that tracks across lots of countries around the world, that there's sort of an acceptability, especially if they're partnered or in marriage, that then it's considered okay, I guess, because the sex is sort of socially sanctioned at that point. Any other closing questions or comments for Chloe before we wrap up? Okay, well, I want to thank you all for coming, and a huge thank you to you, Chloe, for providing insight into these findings. I think it's really, really interesting, and so glad to have this research for a part of the country that I think a lot of times is overlooked, part of the world is overlooked, and especially problematic given some of the stats that you shared about the prevalence of unmet need, teen pregnancy, as well as the gender-based violence. So thank you so much for your great work. And I will hand it over now to Sue to do our closing karakia. One more thing before I do that is just to let people know that next month, on the 28th of August, we'll be hearing from Deborah, who's on the call with us today. And she is doing a presentation on early intervention of endometriosis. So we'll look forward to that and hope you all will be able to return. So over to you, Sue.
Thanks, Ragnar. Ka whakaerea te tapu, kia waitea ai te ara, kia tūraki whakataha ai, kia tūraki whakataha ai, haumi e, hui e, tai ki e.
Thank you all so much. Ka kite.
Ka kite.